Our next speaker is Dr. Stephanie Walsh. Dr. Walsh received her medical degree from the Medical College of Georgia and completed her residency in pediatrics at Emory University. She spent 10 years working as a hospitalist at Children's Healthcare of Atlanta and started treating children with overweight and obesity in a specialty clinic in 2008. With more than a 16-year experience in promoting wellness, Dr. Stephanie Walsh is a leader in her field. A board-certified pediatrician and diplomat of the American Board of Obesity Medicine, Dr. Walsh played a very instrumental role in establishing the Children's Strong for Life movement. Dr. Walsh continues to support Strong for Life programming and content while seeing patients and families in the Strong for Life clinic. Dr. Stephanie Walsh.
Hi, everybody. Thank you so much for having me here. I'm so glad to be part of this meeting and just being able to be here and talk about obesity and obesity care. I am also very happy that I was here for the end of the last presentation, because I will tell you what a very wise woman once said to me, who's a psychologist, and she said, the best words you can say to your kids, because we do have so much time demands on our time, is to say, thank you for sharing me with my patients. And it's just something that brings them into the fact that they are also helping these families. And it's just something that I started to do. And I don't know if it's words that may speak to you, but it may help your kids feel like, hey, my mom's doing that or my dad's doing that. And also I'm doing it because I'm sharing them. So side note, but thank you for having me here. We're going to talk about obesity and obesity care. And I've given some of this talk before, but since these new guidelines came out, everything actually changes every time I give this talk because of new information. So basically, we're going to look at sort of what's been going on since the guidelines came out, how there's a shift in treatment. We're going to talk about comorbidities as well as what it actually means to implement these guidelines in your office. So some of the first part is going to be a lot about sort of the information and the guidelines. And then I have some pretty broad case studies at the end. And I put them up there to spur discussion, but really I would much rather hear about a patient that you saw in your office and what might be the best course of treatment, because that's what it really is all about. So here are the guidelines. They came out in January of 2023, and they caused tons and tons of conversation and media and all of this. And while we say they're new guidelines, they're really the first guidelines. There weren't any clinical practice guidelines before this. There were recommendations from 2007. So this is the first time we actually have guidelines on how to treat kids with obesity. And as you probably know, there was also a huge backlash about, okay, you're talking about weight again. What about all those kids who were going to start eating disorders? How do we do this? How do we do this safely? So the guidelines came out, information came out, but we're still really figuring out how do we implement these exactly in our office? And I'll give a little jab to the AAP. As they like to give lots of big orders out there, that's really great, but how do I do it is the real question with some of these things. So what do the guidelines say? Well, there's 14.4 million kids who are affected by obesity. We all know it's one of the most common chronic diseases of childhood, only behind dental caries. So it's pretty high up there. It's very complex, and I like that say that from the beginning. So in other words, the fact that we've been trying to treat obesity, we've been having conversations in our office, folks have been making changes. The reality is it's complex. And while it's nice of them to say that, we kind of knew that already. Because if it was easy, it would have been solved already. One of the biggest things that they talk a lot about is that obesity is not a personal choice that we have, and that it's really important for us to have access to evidence-based treatment. Again, really a great idea, but what does that mean? What's actually available to our families and what's out there that we can help them use? So what did the review talk about? It talked about effective clinically based treatments for obesity. They want us to know what those are and what are the risks of comorbidities in children with obesity and how good is the screening for it. So if you're going to order the test, what does it mean and what does it matter? And this is what they wanted to make sure that we had. We had evidence for effectiveness in treating obesity, which treatments are effective, and how to leverage resources for treatment. Again, Great ideas. Love them all. What they aren't is prevention, which we all know is probably that key piece for dealing with obesity, right? And what does prevention mean? What does it look like? And what is actually effective? We haven't really addressed any of those pieces yet. It's not talking about the itty bitty little kids. There is information about how to actually treat some of these comorbidities, but that's not part of this either. Again, the approach is looking at, I love this, multifactorial set of socio-ecological, environmental, and genetic influences. But the most important point is what we think is happening is that there's epigenetic changes that are changing alterations in energy metabolism. So while it's not in the genes, is it in the genes? Epigenetics is sort of that thing that's out there. And what do we do about that? So now we have our kids who are eating the same foods or different foods, and they're metabolizing it differently. And what does that really mean for us as we're trying to care for families and give them guidance about the best way to do that? Because if their genes are changed, then what does that mean and how do we go forward? There was an amazing focus really talking about health equity, and a lot of what I heard you guys talking about earlier. What does it mean to live in a rural community? What are the resources here? What do we have that we can use? How do we make this a little more equitable? A big focus on the impact of trauma, food insecurity, and any other of the ACEs that can really impact some of these epigenetic changes. So what does that look like, and how do we address that and make sure we're addressing it when it comes to dealing with obesity? Talked a lot about weight bias as well, and I'm going to dive into that a little bit because it's something that is so out there these days, and the more the medicines are out there, the more it's actually okay for people to say things to people about weight. You do know there's medicines for that now, right? And my kids are hearing these things, right, in clinic, and they're coming and going, I don't know what it is, but everybody's thinking they can tell me what to do because now there's evidence-based treatments, right? So the weight bias is actually on an uprise, which is ironic considering this whole thing talks about how it's not personal choice. And I also put up here these pictures from the Rudd Center. And I don't know if you guys are familiar with that. She was at Yale. She's now at Connecticut. But the Rudd Center has really great photos. So if you're ever looking to update your website or put on a flyer, they have great photos that everybody can use that show kids of every different color and every different size doing healthy things, as opposed to just those photos we know where people are showing people who have overweight as, not showing their faces and the other horrible pictures that we all know about. So the AAP actually has a whole paper about stigma and the stigma period experienced by children and adolescents with obesity. I don't know that you need a whole paper on it because it's pretty clear what's going on, but there is one, which is really nice. And we all know what these kids experience. Even some of the smallest little things to think about is who fits in the desk. How big or how small do you have to be to fit in a desk? And if you don't fit in a desk, then you have your own separate table. And talk about being isolated and the ability to be picked on and made fun of, right? Like, again, looking at that, what does that look like? Asking our kids about these kinds of experiences. One of the biggest things that's changed, and I don't know how many of you guys use person first language, but it's different. We're so easy to say the overweight kid, but that's not what we actually do for any other disease, right? We say a kid with autism, we say a kid with hypertension, right? But it's so ingrained in our language to talk about the, obese child. And if you go back and you look at your records, it just flows out of your mouth. I bet you've been saying this as well, because I have to catch myself because it's just such part of the vernacular. But changing it from Lamar has obesity and Lamar has overweight. And yes, I did get instructed by one of the journalists once that is not grammatically correct. And I basically told her I don't care. But, this is how we're going to say it when we do it. And it's really that whole thing. It's a disease process. And the more we can start to say that, the better it will be. But it is something we have to catch ourselves, and we have to educate the entire office staff when they're starting to document things about this. And when it comes to trying to figure out your own bias, that's probably the best way to start. I think a lot of us have heard about the Harvard implicit bias test, And that's a good one. And you can take that about just about anybody or any condition or anything in particular. And it gives you a chance to just really think about where you have your own hidden biases. And we all have them. So I think just acknowledging them and looking at them is just important. And I look at these other ones. They don't even use person first language in their obese person scale, right? So again, this is how it is. And I challenge you when you start to read an article, if you see how many of the articles are not using person first language with them either, because I do reviews and I would say about 80% of the ones that cross my desk, I'm always having to change everything to person first language, because even the articles that are trying to do research around this aren't using the right language. So I prefer the Harvard one, but these are other ones in particular that have been validated as far as kind of having people take a look at how they're feeling about people with different weights. Let's get back to the guidelines. Soapbox off, moving on to something else. When it comes to obesity care, the real thought is that this is a really comprehensive process and it's chronic, right? That is what is also something we haven't thought about. And that is that the kids come in and maybe have gained a little weight and then they lose some, but realizing that the fact is it might be something they deal with at all different times of their lives. And for us to look at it that way and not look at it as, well, you were able to lose weight doing X, how come we gained it all back, right? And then starting to look back at them. Now, are there habits that we could all do to be healthier? Absolutely. Could we live in a society where healthy food is easy and preparing it's easy and everybody has time to play outside and it's safe to play outside? Yes. But that doesn't necessarily mean that we have that. So we have to sort of look at how we can help kids along the way. The most important thing that we talk about too is that they really need a medical home. And I think while obesity care is great and I can do it up in Atlanta and I can prescribe some of these medications, nobody's coming to Atlanta from around here. Okay? They're not coming. So it really doesn't matter if we have a great program up there. I can't get people from South Atlanta to come up to the other side. Never mind everybody from down here. So it's important that if this is an issue that matters to you and something you want to be able to offer your patients, that you start thinking about this and figure out how to add it in. Easier said than done. I'm not saying it's easy, and you'll have my phone number at the end. If all of you don't have it already, you can feel free to call me and we can talk about these patients along the way. So I don't know how many of you guys have ever taken Strong for Life's motivational interviewing training? A few of you. So one of the key components when we talk about weight and overweight and obesity with families is to use something called motivational interviewing. And it's been around for a long time, since probably the 60s or 70s. And it was really in the adult world when you used for addiction care mostly. And it's really the best way or the most effective way, and endorsed by the AAP and all that other great stuff as far as having conversations around weight that are destigmatizing as well as not likely to promote an eating disorder. So this is some of the skills, and I know Strong for Life would love to come down. They do trainings all the time. I actually think there's a virtual one now, and it's about an hour and a half, and it just goes through some of the basic principles for motivational interviewing. When you're doing care, you also want to set collaborative goals. And this is always that funny one because it's really about meeting people where they're at. I get letters back, and I'm going to talk about the endocrinologist too, and the endocrinologists all the time if they see the kids, and they have a list of 10 things that they told the kids. 60 minutes of activity a day, 5 servings of fruits and vegetables, decreased screen time, sleep, and they just list them. And I'm like, what good is that? You know, so you just gave them a list. They're not doing any of that. You didn't set a goal, because maybe they're doing really well with sleep. They're going to bed on time, they're waking up on time, but the reality is they're taking their phone to bed with them. So that's something you can work on, right? Those are the goals that you can start setting with people, but make them collaborative. Have you guys heard about these IHBLT programs, the Intensive Healthy Behavior and Lifestyle Treatment? And I only remember those letters because it says BLT. So that's all. But these are the greatest idea of what's coming out. And these programs you can kind of see laid out down there. And it is the idea that in communities, you can have programs where families can go to, where they have access to information about nutrition, they have activity, and there's a collaborative setting. Now, Strong for Life is currently piloting this in Gwinnett with Gwinnett Parks and Rec. And I'm hoping, we started in January, so I'm hoping pretty soon we'll have some data and be able to look at how we can get these programs out in other areas. But it's really exciting, and Parks and Rec have been a great partner with this. The idea is to use the USPF, Preventive Task Force hours of 26 hours, and to get that in a 3 to 12 month period. Because there's no clinic, there's no program that can do 26 hours, right? I mean, I think to me, I was like, what are they saying? What do you mean I have to have 26 hours with my patients to be effective? How do you want me to do that, right? And so these are programs that can help augment some of that so that the folks have somewhere to go. We're doing ours in group settings. Some of them can be individual, but most of them are in groups. And the CDC actually has several programs on their list, some that they've actually evaluated and feel work best in office settings if anybody is interested in implementing some of this with them. And I know that UGA and Morehouse also just got grants from the CDC to help bring some of these programs around here too. So hopefully we'll be seeing more of them that are available. So when it comes to diagnosis and management, we have BMI. Is it perfect? No. Is it good? Maybe. It is a screener tool, right? It's what we have. It's in our EMRs. We can just sort of throw it in there. But it is what it is. So I always get, when I give these talks, what about the football player? Okay, if you're looking at a football player who has a lot of muscle and no fat, and their BMI is high, I don't care, right? You can just sort of check it off and be done with it. But it is what it is. It's not the best. There's lots of people who spend hours and hours discussing BMI and how good it is and how good it isn't. I'm going to leave that to the CDC to figure out and come back with something else when we're ready. So the qualifications as we have it now is, what is overweight? Greater than or equal to the 85th percentile of BMI. Obesity is greater than the 95th. And words we're trying to use now is class 2 obesity, and you can see the definition there, and then class 3 obesity. Right? So that's sort of how those are the new terms everybody's trying to use, because what I know when I pull up Epic, if I put obesity in, you know what comes up? Obesity due to excess calorie intake. Well, that's not stigmatizing. Let's throw that on there after visit summary. Come on. Right? And you don't know how many calories they've been taking in. So it's just, this is actually just using the objective data as opposed to putting subjective impressions and comments onto things. So again, we're talking about motivational interviewing, and as we're setting goals with folks, we want to assess their readiness to change. And some of that is stuff we do already. I think that one of the things about this care is that as pediatricians, we're good with families. If we're not good with families, we're not in our jobs, right? So again, continue to use your skills and your relationships to build on it, right? It's a partnership, but that's all we ever do is partnerships because we work with families. Again, let's get from the families what's important to them, and then get to some sort of acceptance of what's going on and where everybody's at. And then, of course, doing it with the kindness and empathy that we do everything with. Because again, as was said earlier, you guys are meeting your families in Walmart, and you're meeting them at the grocery store, where they obviously turn their carts away from you all, as I heard. And if it makes you feel any better, I had people not eat with me in the lunchroom at the hospital because they didn't want me to see what they were eating, like I cared. But that was, so it happens all the time in the world, yeah. So when it comes to communication, they're really talking about asking permission. This is one of those keys that I use all the time. I use it with my kids. I use it with my fiance. I use it with anybody I run into, because asking permission de-arms people and it gives them back control over the conversation. Right? So ask permission to talk about it. Ask permission to discuss their health. Ask permission to talk about their weight if you want to use that word. You can go ahead and do that. And then you have to be ready for them to also say no. Maybe now is not the time. And you probably already know, because you all know your families so well, that grandma is sick and they need to get out of here. So today is not the day to have this conversation. But asking permission helps give people a little bit of control of the conversation. This is what they said in the document are words that they don't like. They don't like child with obesity, and they don't like obese child. So obesity is not a word that people want to hear. These are the sort of more neutral words that parents felt were okay, right? So gaining too much weight for age, some of these, and some of them may work for you and they may not. But I think as long as we're doing things the way we do them with kindness and empathy, it all sort of works out. You want to use whatever words come naturally to you, as long as they're not stigmatizing. So just think about it as you're saying it now, like, could I rephrase that a little bit differently so that maybe it comes across a little bit in the way the families say they want to hear things. When it comes to the medical evaluation, they really want us to screen, look for comorbidities, and really look at these weight-promoting medications. And I know that's small, and I actually hate it when everybody says, oh, I know that's too small to read up there. But I was basically just letting you know, in these guidelines, there's a massive list of drugs that promote weight gain. So go ahead, you can print it out. The Institute for Healthy Childhood Weight has a really pretty picture of all these medications, just so you kind of have them on hand. And you can know, like, oh, maybe if I've given the choice, I should look at this. Or if I have a kid who came in gaining a little bit of weight, should I look at maybe their medication list and cross-reference it on something like this? I will tell you the one thing that surprised me was cetirizine, that is actually more weight promoting than the other allergy medications. And I was a huge cetirizine fan. And I can't even tell you how many kids I put on it because I think it works so well. So just no. And again, I've been doing an obesity clinic for a long time and I've been putting kids on cetirizine. So sometimes they're better despite us, not because of us. One of the things that you guys see more than certainly I see, because by the time the kids get to me, they're usually a little bit older, but are some of these kids that are having some pretty rapid weight gain early on, right? The stuff that you're like, hey, could this be syndromic? Is there something I'm missing? And Rhythm Pharmaceuticals has this amazing test, and it's free, and it's a buccal swab. You send it off. They send you back a really long document that usually says some changes of non-specific understanding. But the most important thing is they have a phone number that people can call to talk to a geneticist. So this is a good screening tool if you think kids have anything that might be really, you're like, I just don't like it. There's a big family history. The family struggled the whole time. They have 2 parents who've had bariatric surgery. Go ahead and screen these kids in case you can find some of these things. And what I like most about this is they are getting that database. It's all de-identified by the time it gets back to them, but they're getting a database of some of these genetic changes so that we can see what's going on. And I've actually had several kids that we've screened that have come back with something. I had one patient actually who came back with something, and it wasn't a gene that I particularly knew about, but it was known to be associated with obesity, whose mother, Spanish speaking, had DFACs called on her twice because she was not controlling her kid's weight gain. I mean, talk about validating, right? Also, right, this whole idea like, oh no, she's not doing something, she's not. And I tell you, I very much enjoyed calling that pediatrician to tell them who called DFACs twice on this mother. So, it's one of those things that we really, if you're worried, just go ahead and do it. We've started sort of just doing it on all the patients that make it up to Strong for Life, just because it's there, it's free, and I think it's important for families to have access to. So that's a really good test. So when it comes to labs, these are always the questions. Should you get them? Should you not? You got them last year. When should you get them again? So they're saying basically a lipid panel and LFTs from 2 to 9 years, if clinically indicated. Basically use your own judgment. You got it. You'll know if you should screen or not, right? Just give it a try. You can always screen. And then at 10 plus, go ahead and add the others. What is new about this is they talk about repeating it every 2 years or sooner if there are concerns. Before, there was no comments about when to repeat or when to do this or when to do that. So as far as the screening goes, as far as looking for comorbidities, there's strong evidence for dyslipidemia and NAFLD, which I think has changed its name, and I'm sorry if there's a GI doc in here and I don't have I think it's MASLD now. So there's really strong evidence for dyslipidemia, and it's always get a fasting sample. I don't ever get a fasting sample unless it's really abnormal. Okay, because I'm there, I'm getting them. I don't like my kids to come to clinic really hungry. It's a long visit and then they're cranky. I don't need cranky kids in my office, right? So go ahead and screen for the lipids. If it's really abnormal, you can get another one that's fasting. But most part, what you're going to see in kids with obesity is maybe a highish cholesterol, a highish triglyceride, and a low HDL. Sort of classic. So unless it's something that I need to send to cardiology or lipid clinic, I'm okay. We'll just keep following it. There's moderate evidence to screen for type 2 diabetes and prediabetes as well as hypertension. Part of that is that it's so funny because it used to be, I remember training going, you can get the glucose, you can get an A1C, and then you can do that oral glucose tolerance test, which is the end all be all. And now they're saying none of that's the end all be all. You got to have more than one test. And, unless it's, really abnormal and then repeated. So the endocrinologists have really messed up my head about this. I don't know the answer. I do the screening. And then if I'm concerned, I usually end up repeating the tests in a couple of weeks to see if things have changed. And that's actually a big thing about liver enzymes too. I usually repeat those in a month if they're high, because remember that liver enzymes can be elevated with any sort of viral infection too. And with the high blood pressure, the reason the evidence is only moderate is because there's thoughts now that kids with obesity and overweight tend to have a decrease in their nocturnal dip. So it's not so much that their absolute number with you is high, which of course would be an issue, but that's really the first signs that they're having some more hypertensive concerns. And that was why the recommendations from the American Heart Association are ambulatory blood pressure monitoring cuffs. I don't know how many there are at Children's, but about 5 years ago, there were 4. So I don't know what to do with those recommendations of ambulatory blood pressure monitoring either. And don't forget to really ask about sleep disorders, PCOS, mood, and pseudotumor, right? The amount of sleep apnea that we're seeing is rising. I would say initially I was doing sleep studies and I was getting about 50% with sleep apnea, and those numbers are probably at 80+% now. So the sleep apnea is really increasing. Some of that might be because I'm seeing kids now as again, pediatricians are taking care of this disease more in their own practices. I'm seeing heavier and heavier kids or sicker kids up in Atlanta. Again, when it comes to treatment, you have to have the chronic disease model, and this is the biggest change. When you diagnose, you're supposed to treat. And you're supposed to treat with the highest intensity available, which I actually thought was the nicest thing, because it's basically what you got, right? So use what you got. There's no more of the watchful waiting. There's no more outgrowing it. There's no more, oh, it's just this, oh, it's just that. If you diagnose, you're supposed to treat and to use motivational interviewing. And treatment using motivational interviewing actually decreases the risk for disordered eating up to 6 years post-treatment. That's like a sentence that was sort of like, I think, left out a little bit of all of this. Because every kid that gets to Strong for Life Clinic has disordered eating. Do they have an eating disorder? Probably not. But do they have disordered eating? Yes. Because all of them have tried whatever is on TikTok, whatever they saw on Instagram. I made a goal yesterday with a patient that he's not allowed to try anything on TikTok before he brings it to me. Right? He has to show me the video first before he engages in whatever diet has popped up for him. But realizing they're all trying stuff, even if they're not telling us about it. So as I started all this, I, of course, got asked for multiple conversations with folks who do the eating disorder work, and they have been really wonderful. Again, they really feel strongly that we need to do eating disorder screenings and make sure that our kids aren't having some of the pathology around eating ahead of time. It's a little hard because, again, our kids have been through so much trying to manage their own weight. So this is the purple book. This is the book according to them. And so it's just a resource for you all. This is one of the tests that they have, and you can see the questions there, really looking at, do you make yourself sick? Are you losing control? Do you believe yourself to be fat? And would you say one food dominates your life? Because that comes from a lot of those sort of fad diets that are out there. Great tool, not validated in teenagers. There is no tool that's actually validated in teenagers yet. So go ahead and screen, but I don't have a really good tool for you. But these are things that are out there that you can use. And even if you don't use them, it's sort of important to think about what's going on about, how are you eating? What does it look like? Are you restricting? Because realizing even starting some of this stuff, then you start to see the kids who start restricting. Here's another one. Are you satisfied with your eating patterns? Do you ever eat in secret? Right? So you have to really build on that relationship that you have so that they feel comfortable saying that to you. Sometimes I say to the kids, a lot of kids tell me that they like to eat in their room or they kind of eat in secret because they feel like there's a lot when they're eating in front of other people. Right? So I've normalized sneaking. I've normalized it, and I'm expecting them to say yes. Or how often do you think that you kind of take food and go and eat it somewhere else? Right? Again, normalizing it so that they can tell me 2 or 3 times a week, once a month. Again, keeping that conversation open. Does your weight affect the way you feel about yourself? I think there's so much body dysmorphic disorder out there that everybody's weight impacts how they feel about themselves. It's so prevalent. Have you ever had an eating disorder? Do you have family members with eating disorders? Because we do tend to see them running in families. And then the PHQ-9 even has one question about it, right? Poor appetite or overeating. And sometimes you also need to ask the parents, what are they seeing? Are they seeing them sneaking or hiding, finding wrappers and those kind of things? So here's the real nuts and bolts, and probably the thing that you guys want to hear the most about, and that's medications, right? So it's sort of like, what's new, what's the evidence, and how do we use them? Oldies but goodies, metformin. Metformin is not approved for weight loss because it did not meet I think it was 5 kilogram weight loss in the studies, but there are some people who love it. And just as I had to add that sentence in because about 3 months ago, a patient came in and her aunt said to me, she does great on metformin. And I said, okay, it's not approved for weight loss, blah, 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 blah. And she came in 10 pounds later. So I had to eat my words, right? And just say, some people love it and it works for them. I always start with the dinner dose, 500 to 1,000. I don't add a morning dose unless they have the diabetes because they don't eat breakfast. So if you're not eating breakfast and you take 1,000 milligrams of metformin, guess what? You're going to feel really bad. And then you're going to stop taking your nighttime dose of metformin. So I'd rather them get some in, even if I can't get all of it in. And XR does help some. So if you have the chance, I'd write for XR, and you can always just go to 750 and leave it at that. What do you need to get before you start metformin? CMP, looking at LFTs, kidney function, GFR, and they want yearly CMPs, B12, and folate. I should have highlighted this, the one on the other side. This is the first line treatment for any children taking any atypical antipsychotics, any antipsychotics. So if you know your kid's getting put on Abilify, put them on metformin right away. Right away. And I am trying desperately to get the psychiatrists to do this. They don't always feel so comfortable with this, but they're happy to put them on Abilify or the other stuff because they will have a weight gain with that. And then we can go ahead and start that. And even if they've gained weight on it, go ahead and put them on the metformin because they can see a decrease with that. I've had some kids who stopped gaining and some kids who've lost once they've started the metformin. And again, I try to get to 1,000 at night if I can. Otherwise, I'll do 750. Remember, it does help with PCOS symptoms, but it doesn't do anything for the hirsutism. And Orlistat, my only Orlistat slide, because I think the picture's funny, right? Because nobody takes Orlistat. It's probably still in the drugstore. It causes, kids to have very bad bowel issues. So it's out there. It's approved down to age 12. So it does exist. All right. And I will admit, this is my go-to medication because it's cheap and easy and available. Right? And that's what it is. And it works when you take it, and it doesn't when you don't. And so that's what I like about it. So the phentermine and Topamax combination is approved down to age 12 too for anybody with a BMI greater than the 95th percentile. And remember that number because when we get to case studies, I'm going to bring that up again. Phentermine's usually not covered, but it's somewhere around $15 to $30 a month. So for many people, it's at least affordable. The dose is anywhere from 3 milligrams to 15 milligrams, but I can tell you getting anything but 15 milligrams is very difficult. So I usually just start everybody on 15, and getting 15 milligram tablets is almost impossible as far as cutting them in half, but you can find the capsules. I have, for some of the younger kids, started them on the 8 milligrams, and we've just tried to be patient while we get some of that in. Topiramate is usually covered. The dose is 25 milligrams. You take both in the morning. There are folks who are taking the topiramate level from 25, then to 50 to 75. You can separate the two of them if you're going to take it up that high, because remember, we like to call Topamax Dopamax, so sometimes the kids feel a little fuzzy with it. And this way it can actually get even broader coverage. I usually start with the 25 because that doesn't usually cause any of those side effects. And then if they're really not getting enough of the appetite suppression, I will increase the Topamax. Other people start with just increasing the Topamax as well. Some people like the higher Topamax level when they're prescribed. I find that what happens is I'm then backing people off from a 75 milligram of Topamax. That's my experience. Go ahead and try what you want. These are two medicines that are easy. I would suggest when you're trying to think about how do I start with these medications, that you start with these, because they're easy to get started with. And it's like everything else we do in peds, as we're taking care of more and more adult diseases, just got to start trying, right? Like, I'm pretty good with lisinopril, right? I'm pretty good with a couple of OCPs, and I'm pretty good with a couple of, depression medicines. You kind of get your couple. So you kind of start it off and then you can expand from there. But this is the study. It's been great. I've seen really nice success from this medication. So I've always checked them after 1 month, just because you want to see how it's going. You check a BMP every 3 months. These are the side effects. And the biggest thing, obviously, is the fact that it can be a teratogen for any of your girls who are not on birth control. I do not do pregnancy tests before I start girls on this. That's my own thing. I'm kind of making a political statement and saying, I talk to the girls, we talk about it. If they're sexually active and there's a concern, yes, we'll do a pregnancy test, but I don't force them. The adult docs are often forcing. I feel like this is like an Accutane thing again, like they're forcing all these pregnancy tests on everybody. The biggest thing to also think is tingling and numbness in the hands and feet. And that's because you have to stop the Topamax if you have that. So that's the one thing too to think about. They say worsening anxiety and depression. I have not had that. I've actually had my kids with anxiety do really well with this. So again, you can think about it and you just have to monitor them. And here's the big ones, the Ozempic craze, right? Everybody's out there. I'm going to get my Ozempic so I can get down to a size 2, all that stuff that's out there. These are now approved down to age 12 to 17. Are they covered by Medicaid? No. We're trying. Hopefully soon. I actually saw an article come by on my phone this morning that said GLP-1 agonists are going to bankrupt Medicaid. And I'm like, well, how about if people lower the cost of them, right? As opposed to bankrupting the government. Yes. So they're super effective. People do really, really well with these. Decrease appetite, slows gastric emptying. They are an injection. BMI of greater than 30 or greater than 27 with one weight-related comorbidity. So a little bit higher, right? As far as absolute numbers. We don't actually have it in the same thing of like class 2 or class 3 for obesity. And here's the ones that are listed. Liraglutide is covered by Medicaid on their website. I haven't gotten it approved yet, but it is supposedly covered on the website, right? But that's the daily injection. And what we're kind of still playing with is the weekly injection of the Wegovy or the semaglutide versus the daily with the liraglutide. And sometimes people have gone back and forth. People have been doing this a little bit longer. People say, well, if they didn't do this one, then I tried this one. Okay. But again, you're talking with where it can where somebody who has the access to all of these kinds of medications too. So I just wrote to advance somebody through this, and mom just texted me this morning saying the 1.0 dose is not available. So again, as we're taking people through, there's still shortages. It's still an issue for everybody. So this is the liraglutide. I have never gotten that approved or had anybody take it. So I really don't have any personal experience with this, but we've been doing a lot of semaglutide / Wegovy, weekly injections, starting at 0.25 milligrams and then working up to 2.5. You go up every 4 weeks. It works really, really, really well. The question is, again, on everybody's mind, is what happens when they're at the max, and how long do you stay on the max, and what does it look like when you come down, and will insurance pay for, them going from the 2.5 back down to 1 so they can do maintenance? Like, there's all these things that are still out there that are unknown, right? And I do have a girl, actually, and we've been talking about, now that she's sort of at where she wants to be, what does it look like for her to come off? There's some data out there now that's saying, well, maybe it does actually change some brain chemistry. Maybe it does reset your set point. Maybe we'll be lucky in peds and this will actually do that. And it might be different in adults. We just don't know yet. So there's a lot of things out there that we don't know. And the articles are coming out day after day. And it's just really, it's hard to keep up or understand. I don't know if you all saw, I see them, but, because it comes across that, there's talk that semaglutide is actually really beneficial from a cardiovascular standpoint. So that's coming out there. That's all in adults. So what does that mean for kids? We don't actually really know yet. The contraindications you can see here, history of pancreatitis, which also means it's sometimes hard for some of our kids who have autoimmune disorders because a lot of them have had pancreatitis. Anybody with lupus, is this really a good, option for them or not? I always send in a prescription for Zofran, because people do tend to have some nausea. Some people have a lot. Some people only have nausea when we increase the dose as you go after 4 weeks. So it's just good for them to have some there. They say check a glucose prior to starting. Okay. Most likely going to be normal before you start, right? And then there is no recommendation for hypoglycemia education, but it is out there. And sometimes I think people do talk about it. This is my new favorite drug for all my kids who've had bariatric surgery. I wish it was approved a little bit lower than 18, but it's approved for 18 and above. It's very activating. So I have them take it in the morning, and then they take 150 milligrams to start, and then they increase to 300. It's indicated for this BMI, also works with ADHD, depression, and if you've used it before, it's also a potentiator for other depression meds and actually can help with some of that. So this medication has been really nice post-op as the kids are losing and then sort of plateau and then can sort of get back onto some of it. Here's are the contraindications: disordered eating, which kind of makes me laugh with what I do, and also pregnancy, uncontrolled hypertension. And here are some of the side effects. I had one family who was insistent that this is what caused their sleep disturbance. It's not actually reported as something that does that, but it is activating, which is why I give it to folks in the morning. And stimulants, and this is where I'm also going to talk a little bit about one of the things that these medications have allowed us to do, and that is treat hunger. So you may have some of these kids who come into your clinic and say things, my kid is hungry all the time. So you try the behavior pieces, you try the different parts of sort of how do we, high fiber snacks and making sure that we don't have food out, so it's tempting and all those things. But there's some kids who just need their hunger treated. Like that little boy I told you about who has a genetic issue. Before I even knew he had the genetic issue, I started him on some Concerta. And you know what? He stabilized. And you know what he said to me? I'm not thinking about food all the time. Great. Because there's food noise in heads sometimes. And so sometimes addressing that and helping the kids be less hungry with less food noise is a little bit of what they need. And that's why I like the phentermine and the Topamax so much, because it does address some of that food noise too. So stimulants, I do for impulsivity around food. It's obviously, off-label for weight loss. And I just document that's what I'm doing. You guys do more ADHD medicines than I do. I can't get Vyvanse anymore. I don't know if you guys can. So I pick a different one and sort of try. But Vyvanse is approved for binge eating. So if I have some of the older kids that we can put on Vyvanse for binge eating disorder or who have a history of binging, this can also work really well for some of them. But I do think that there's a real place for stimulants in practice and in weight management. Again, off-label. And again, you have to kind of try it. You know your families. You guys know them better than I ever know any of my patients. So if you feel like there's a lot of hunger and a lot of food noise, give it a try. So the Institute for Healthy Childhood Weight from the AAP has all these really pretty pictures of all these guidelines and everything that you might need. They're a great resource. You can go there, print them out. And like I said, I think one of the most important pages is that one that has the weight promoting drugs, just so you sort of have it right there. But they talk about a lot of really important pieces. Now, it wouldn't be new guidelines without another focus a little bit on bariatric surgery. And they did come out with new guidelines for bariatric surgery a couple of years ago. And the ASMBS, the Adults, Obesity Society, AAP, all came together and put together the guidelines for bariatric surgery. Bariatric surgery is the most durable form of weight loss for teenagers. The most durable. Okay, we know that it's the one that has the most evidence that there's a reset of the set point and all those pieces that we know are important. So who gets it and who's eligible? So you have to be 13. Do I love it when I have a 13-year-old? Nope. Because then they get their license at 16 and they have what I call the Starbucks phenomenon, right? And all of a sudden Frappuccinos are available to them when they get their license. So I don't always love the younger ones, but that's my bias. The research supports that 13 to 15 do as well as 16 to 18. Okay, so I try to get out of my own head about some of that. It also supports that kids with intellectual impairments, kids with autism, I've had several kids with trisomy 21, all do phenomenal. So that's also not a reason. Anybody who thinks more concretely does better with bariatric surgery. So one of the things about it is, again, diabetes goes away almost instantly. So the kids who come in on diabetes medicine almost never go home on anything, except maybe a PRN glucose check from the endocrinologist. You do have to watch out for micronutrient deficiencies. There's one case study of an adolescent who ended up with beriberi from thiamine deficiency. One. So that's good. Have I been nervous, knock on wood, all the time that we haven't had any of that? Yep, because, teenagers and taking medications, they're no better than we are at taking them. But most of the stuff is very minor. These kids do really well, really, really well. So I strongly encourage you, if you think there's a kid who could benefit from bariatric surgery, you don't have to decide. You can send them up. We can do a televisit or something to see if they are a good candidate and how we can best move forward with this. But I will tell you, when I started in this field a long time ago, I was not pro-bariatric surgery. And the bariatric surgeon at the time was just starting and sat next to me in lunch and bugged me to no end to come and see these kids. I'm, by the way, now engaged to him, so I will say something happened. He's very convincing. But it was true. Once I saw that this was something that was effective, it's kind of like how I feel with these medicines now. There's a tool. There's something. So there's a really comprehensive program in Atlanta, and I know in Augusta as well. There's multiple visits. There's a full team, nutrition, psychology, exercise. So it's a very comprehensive program for this. So again, taking into account the whole kid and the whole family. And I think it's really important to make sure there's pediatric providers, because, a 14-year-old kid with obesity is probably not even 14 necessarily socially, right? They've been shunned, they've been bullied, they don't have as many social interactions on the most part. So you really need somebody who understands development when we're talking about these kids and surgery in particular, because in the end, you know what? You have these kids who then all of a sudden are getting all this social attention, but they haven't gone through the stages, which is why the teen pregnancy rate after bariatric surgery is twice the national average. Because you're fertile, and because you got the attention. And again, you haven't gone through all those necessarily developmental stages along the way. So we're also using medications with pre and post-op too. And to realize that there's a lot of psychological benefits to using medications even before surgery. So even if we're sending a kid up for surgery, you still know that we may do some medications as well. So pre and post-op, we're now playing with this. We don't have a ton of data to say this is the right one. They're actually coming out as something with the impact of the GLP-1s after bariatric surgery in adolescents, but I don't even have an actual paper to share with you. But this is the use of phentermine and Topamax. And one of the things without this is I have a couple of kids who do really great with this. But after bariatric surgery with a sleeve gastrectomy, it removes a lot of the ghrelin-producing cells, so therefore they're not hungry. So I'd be really careful when you're giving kids medications after surgery, because if they're already not hungry, I'm not giving them something to make them even less hungry. Because sometimes what they need to do is actually just eat more regularly, right? So we sort of talk about that. But it has been shown to be hugely beneficial afterwards. But again, these papers are all coming. So there's tons of gaps in what we know. We don't know how long to treat. We don't know long-term weight loss. I don't know who gets what. So when I have a kid who comes up for bariatric surgery and both their parents had bariatric surgery and lost a lot of weight, I'm like, yes, because maybe that means that this kid's going to do really well with bariatric surgery. One size doesn't fit all, and I don't know the appropriate dose. I actually have a patient who has achondroplasia who is now on Wegovy. So what's the optimal dose for this kid? I know, right? So we go slow and we try. So we do the best we can. Okay, now we're just going to do some case studies. And again, these are very broad, and I'd much rather talk about it. If you have a patient you want to talk about, I'd much rather do that. So raise your hand if you have someone you want to talk about. But here I have this. I had this kid just come in. She actually just came back for follow-up. She's a 12-year-old black female with obesity. So what do I know? Just by that information, I know that lifestyle interventions of the basic ones that we do with diet and nutrition are actually less effective in the black community than they are in other communities, right? So again, maybe lifestyle isn't the only thing that I start with here. Is it important? Yeah, I got to start with it. But do I need to think about adding other medications sooner? She's 12. So does she meet standards? Is she old enough to get anti-obesity medications? Just, right? Just. So what is a 12-year-old brain? It's kind of scary, right? I mean, as far as giving this, what's up with her body? What are her eating habits? She's someone I definitely want to spend some time with, talking about how she eats, what she eats, but more about how does she think about food? I want to get an idea for the food noise in her head, right? And notice I didn't tell you what her percentile was, right? Because does it matter if she's 160% versus if she's 110% of the 95th? Technically, they both qualify, right? So am I putting my own judgment and bias on what I think should happen, what I think this girl should be able to do, and those kind of things? That's why it's great to have guidelines, but implementing them is difficult, right? So we had a girl who came back. So I don't remember what her percentile was. She came back in a couple of days ago. She lost 10 pounds. She is thrilled. When I talk to her, though, guess what she's doing? She's restricting. And she was really upset that she was not getting praised for her weight loss. She started crying. You think I had like the flags going on? All over my head, right? So again, we continued on the medications. We focused on eating and making sure she was eating regularly. And I'm seeing her again in 1 month. She doesn't get a 3-month break, right? She comes back in a month. Remember, when you change somebody's hunger, they need to know how to eat. I'm not hungry like I used to be, so how do I know what to eat? We have handouts, we have information, we have nutrition visits. We have those pieces. So it's really important to make sure that you talk to the kids about getting in their protein. She actually told her exercise person she didn't want to exercise because she was worried she'd build muscle and gain weight. Lots of education that needs to happen, right? And I had a private conversation with mom. I said, will you please call me? Just so we can look at sort of the restricting, because what we don't want to do is exactly what these guidelines, what the fear was, right? Is, are we helping this girl engage in her pathology around eating, right? I have several 12-year-old girls who've done great. You give them some medicine, they start to eat regularly, they tell you everything is good, lose everything very consistently, exercising and all of that. But every kid is different, and that's the fear, right? So the guidelines are there, but this could be 12 different kids that walks into your office, right? It's not as simple. But you guys know your families. You know the kids. So I have no doubt that you guys can do it too, because you already know them and you know what's going on. Okay, here's a 14-year-old with obesity, has ADHD and is taking a stimulant. But he wants to lose weight. What are your options? Should I throw in there that he's on Medicaid so you don't have a GLP-1? But a GLP-1 would be an option, right? Because you can do that with stimulants, so that's good. Start him off on that, see how it goes. That'd be great if he didn't have Medicaid and you could do that for him. One of the things that you can't do is give him phentermine because he's already on a stimulant. So that's my point with this one, right? He's on the stimulant. Is he on a good dose of that stimulant? Could you alter that stimulant depending on what his needs are? But you can add the Topamax. And this might be a kid that you want to ramp up to that 75 milligrams of Topamax, right? Maybe he's someone that as soon as his ADHD meds wear off, he gets really hungry. So could you have him take the Topamax right after school? Might be probably not a bad idea, right? And that'll give him some appetite suppression through the end of the day. And that'll hopefully cover him because maybe he doesn't eat. Making sure he's eating a good breakfast, right? That's some of the lifestyle pieces you can do, making sure he's active. So those are, again, great guidelines, but doesn't always fit the picture. So here's a sexually active female, 17 years old, uses condoms. How do you guys feel about giving her phentermine and Topamax? Nope, I know. Exactly, right? So you're kind of stuck with some of these. And what does this look like? This is a kid you might want to say, hey, we got to do some pregnancy tests. We really have to talk about this. You know, maybe I would feel more comfortable if you were on a birth control pill during this time, because we do know that 50% of pregnancies in this country are unplanned, right? So those are some of those things to talk about. And then talk about it with their family, right? How is she going to feel if she has a birth control pill at home? What are her parents going to say, right? These are all these kind of things. But is it okay not to treat her because we're afraid? Right? So you talk. And again, you guys know your families, you know these kids, so I think that you're in the perfect place to look at some of this. Okay, this is a 15-year-old female with a BMI of 108% of the 95th percentile. Want to give her some meds? Nobody's nodding. Anybody want to give her meds? Does she qualify? Yeah, right? You can give her phentermine and Topamax. She's above the 95th percentile. Just saying, you can do these things, and you could start with lifestyle. You could assess whether or not she's got any pathological eating or anything else that's concerning, and then you can go ahead and try it and see what it does. Maybe you can look at her curve and see that she's going up, and you want to get her back down. So this is a little bit of a trick one. So here's a 17-year-old female. It's not a trick. We started phentermine and topiramate. She's doing well. She had a 10-pound weight loss over the last month. How do you guys feel about that number? What's the appropriate amount of weight loss on an anti-obesity medication? I don't know. How's that? We don't know. But how do you feel about 10 pounds, right? How do you feel about 15? Yeah, that's exactly. Those are all those pieces that come in, right? What is 15? Is she moving herself? Is she losing muscle with this? Is she eating her protein? And then I threw that last one in, right? When do you go, right? What's the number? And I wanted to say, we don't know what the right amount of weight loss or the appropriate or what is. It used to be this 2 pounds a week and all this sort of stuff. There wasn't science behind it. And there's no science now to tell us how much weight loss is okay. So again, you know the families, you have conversations, are they eating well? And you see them again and you do follow up. And I threw this in because, as you know, I've done a little bariatric surgery stuff, but right, this is a kid who probably needs surgery, right? Because you got to get cardiology to sign off on giving him any sort of stimulant, right? But he would probably really benefit. He's already has comorbid conditions from his weight, right? So let's go ahead and get him somewhere so that he can get probably something that will really help. So the key takeaways, when you diagnose, offer treatment, evaluate, using motivational interviewing. I had to refer to the IHBLTs that don't exist yet around here. Use meds and surgery as indicated, and go ahead and try and reach out to me and to anybody else that you need to have conversations around it. Because as I was trying to show you is all these things are different, and all you can do is try. Give it a shot. Pick a medication, try it, and do your best. And I have total faith in you guys. And I don't think I have any more time. So questions. So you'll have to call me. Okay? Thank you guys so much. You have the next person, or can I take a question?
Take questions.
Oh, anybody have a question or a quick question? Yes.
The Rhythm Pharmaceutical swab, you just call them and they send the office and swab?
Absolutely. They send you boxes.
And you just have to do it one by one, or?
No, they'll send you like 10. Yeah. And then you just send them off as you go. Yes.
Where did you say we can get that list of the medications that promote obesity in children?
In the guidelines, they're in the guidelines. So on the AAP, and the Institute for Healthy Childhood Weight also has a nice list. I mean, they have it nicely printed. Yes.
So the swab, again, you said, we can order that, let's say, through this.
Yep.
And how does that get paid for? Like, does the Medicaid pay for it?
Rhythm pays for it. Rhythm covers the whole thing. You just send the swab, you send it back to Rhythm, and they email you something. Yeah, it's really nice. They're doing it for their own benefit. So, right. All right, guys. Thank you so much.
Thank you.